All right. Um, we're going to go over healthcare quality with a focus on the regulatory agencies. That's going to be our theme. It is Concept 48. And for this, I'm taking it from your concepts book. Concept 48, healthcare quality. I also have a little PowerPoint that we're going to go over. I know that kind of changes things up a little bit for me, but I want to do that. So quality. Quality is one of the most important issues in healthcare today. And I want you to go down here and look at this staggering number that always amazes me every time I see it. Oh, I'm fixing to share my screen. I forgot. But just look here at even worse. Healthcare error may be the third leading cause of death in the United States, with 210,000 to 400,000 deaths per year estimated to be linked to poor quality of care. Now, that's a pretty sobering statistic, isn't it? All right, so I'm sharing the concept analysis diagram for quality improvement. Again, as we're talking about this, I want you to be thinking, where does this fall within the concept or subconcept, should I say? All right, so let's look at the definition. So the importance of quality dates back to Florence Nightingale. Y'all, she was the smartest nurse I've still even ever heard of to this day. Florence Nightingale was so far ahead of her time. She is truly the founder of our modern day nursing practice. So, you know, she nursed during the Crimean War in the mid-1800s. She noted that most soldiers were dying of infection of their wounds, more so than from the wounds themselves. Noticing, you know, big thing in our clinical judgment, she noticed that. So then she insisted on meticulous sanitation and attention to patient needs. Again, I want you to think of the holistic care. Within a short period of time after that, deaths among the wounded were reduced from 33%, that is more than a third of the soldiers would die, to 2%. That's amazing, just by using common sense. So not only did she provide the holistic care and sanitary conditions for them, she also kept records. So, you know, when you talk about theories and you talk about research, you keep records. So she kept records documenting these as fact, which was kind of also then maybe the beginning of, or the birth of, evidence-based practice. Initially, her accomplishments were not well received by the medical establishment, and by that, back then, really it talked about doctors. But Nightingale is now recognized not only for modern nursing practice, but also infection control, epidemiology, and hospice care. She was a huge contributor to nursing, even present day nursing. Okay, so turn the page and let's look at attributes and criteria. And again, you see that here on your concept analysis diagram. I'm just looking at the book as well. So all patients expect care to be delivered without error and free of injury. They don't expect that you're going to amputate the wrong limb, that you're going to give them the wrong medication. You know, just a lot of things that happen that they will fall because maybe nobody had safety measures in place to keep them from falling. So safe, timely, reducing their wait times, not letting somebody have a heart attack in the waiting room of the ER, right? Prioritizing care, effective, give me care that will fix my problem, which is based on evidence, is how you're going to give me effective care. Efficient, don't waste a lot of resources. Just give me what I need. Equitable. This is, this is a big one for me because I just feel like healthcare is probably not equitable to everybody that seeks help. I think we have a lot of preconceived notions, and I just challenge you to go out in your practice with an open mind, and you can't judge anybody. Very non-judgmental. This states that anybody in any socioeconomic demographic is supposed to receive the same care, equal care as to anybody else in an upper demographic. And then patient-centered. Remember, as nurses, we care holistically for the patient. We care for the whole patient, not just pieces of the patient or the disease. We do holistic care. All right, so let's look over here at context to nursing and healthcare. So quality is a component of almost every aspect of healthcare services. In the US, we know we have a ton. We have nursing homes, we have hospitals, we have urgent cares, we have freestanding ERs. We have doctor's offices. We have so many different modalities, home health, hospice, of healthcare services that we provide, that we do have to be regulated. Now, am I going to tell you I think that healthcare is very much over-regulated? Yes, I am, because we have so many different regulatory bodies. It's really quite a challenge to meet everybody's standards. So look at some of the bullet points down here below the context of nursing and healthcare. While we're looking at quality and want to improve it for better care. We want to improve the overall quality by making it more patient-centered, reliable, easier to get to, and safe. Affordable care, reduce the cost of quality healthcare for individuals. And we do see a lot of that even in our community. What about the Hope Clinic? They provide care and they charge based on income. So, I mean, that's a pretty good thing to have. It does help make healthcare more equitable. All right, now let's look at the regulatory agency section in the book. So multiple oversight bodies and regulatory agencies exist to ensure safety of the public. Just like the State Board of Nursing is to ensure public safety, not nursing safety, but public safety. Ensure that we are giving the best quality care to our patients. So they license healthcare facilities for operation. They can take away your license to operate if you're found to be not meeting a certain standard. They can fine organizations, restrict their services, and suspend operations. So CMS, Centers for Medicare and Medicaid Services. So one thing, this is what when they say state, states here, states in the building, this is who they're talking about, CMS, Centers for Medicare and Medicaid Services. Why is this so important? So let's talk about what payment source most of our sick patients fall under. It's going to be Medicare because they're older, right? They get Medicare at 65. Well, usually your older demographic is going to be sicker, and they're going to be the ones that are in the hospital the most. So hospitals need all that reimbursement from Medicare for taking care of those patients. And Medicaid. Medicaid, you see that a lot in women's services. It says over 1/3 of the US population gets their health insurance through Medicare, Medicaid, or other public insurance. CMS has been leading efforts to link reimbursement to improve quality. I'm going to read this and I'm going to explain it to you. One initiative is value-based purchasing, which links incentive payments to hospital quality. Hospital quality is assessed through measures of mortality outcomes for specific diseases, selected clinical process of care measures, and patient experience scores. The quality of nursing care directly impacts most of the measures used. Again, the care that we are giving, the standards that we are following. So with that being said, I want to introduce you to pay for performance. P4P is what you might see this. So if you have poor outcomes on mortality or CAUTI, CAUTI, the catheter-associated UTI, if you show that you have an increase in these or you don't meet the standards to help decrease this, like removing the catheter within 8 hours of insertion and the different criteria needed, they can reduce your reimbursement by up to 3%. And you might think 3% doesn't sound like a lot, but when you look at the huge number of Medicare, Medicaid dollars that are being paid out to these hospitals, 3% is significant. So that is the incentive then for hospitals to provide that quality care because they want full reimbursement. Paying for never events, patient falls, patient readmissions. Let's talk a little bit about, let me give you just a little brief DRG, diagnostic related group, little sub lecture here. So Medicare and Medicaid and most insurances have now adopted this. Medicare is the one that put the DRGs into effect. DRGs mean that if you are in the hospital with pneumonia, the hospital is going to get paid one lump sum. This is what you're going to get for this patient. Irregardless of how many days the patient stays in there, how few days they stay in there, what all types of treatments you give or don't give, you're getting reimbursed one amount. When they started this in the 80s, that then drove hospitals to try to become more creative so that they could get the most value for their buck, right? So they were bringing these patients in, treating them, and sending them home as soon as they could. That way, that shorter length of stay, the hospitals would make more money. So then what Medicare found is that a lot of times when these patients were discharged so early, they would be readmitted within 30 days to the hospital, which increased costs then to Medicare. So what they then started doing is any readmission for 30 days or less after discharge, hospital doesn't get reimbursed for. If a patient falls and breaks their hip while they're in the hospital does not get reimbursed for that surgery to repair that hip. So again, you can see a lot of these monetary incentives for hospitals to give quality care because they want to make sure they get the most money for their investment. So DRG, you're going to get paid one amount irregardless of amount of time a patient stays for that diagnosis. All right, but let's go back here. And this looks at some of the featured exemplars, and we know the Joint Commission is one of these agencies. The Joint Commission, they are independent, not-for-profit organization. They develop standards for quality and safety and evaluate organizations based on those standards. Now it says after CMS, this organization has the second greatest influence on healthcare quality. Healthcare organizations that want to participate in and receive payment from Medicare or Medicaid programs must be certified as complying with the conditions of participation or standards set forth in federal regulations. The Joint Commission is an approved accreditor for CMS Medicare certification. So that's just a whole bunch of words to say, if I don't want to participate in Medicare and Medicaid, I don't have to participate in Joint Commission. The Joint Commission is something that a hospital invites them in and pays them to come in and look at all their processes to make sure they are providing care within the standards set forth by that regulatory body. CMS, on the other hand, you don't invite them in. They have purview to come in any nursing home, hospital, any facility. They have the oversight to be able to come in and do that, irregardless of whether you invite them or not, and you do not pay them like you do the Joint Commission. So the Joint Commission survey includes an on-site survey. So they come to the hospital. Usually they're there 2 to 3 days and focus on patient safety and quality and evaluate the actual practices that are used. They'll actually just maybe stand in the hallway of a med-surg unit and watch these nurses go in. Are they washing their hands? You know, are they doing what they're supposed to be doing? And then at the end of it, when they determine whether you have passed and whether you have met all the standards, they'll also give you some things that they saw that they feel like you can improve upon for the next time. So it is a learning process as well. The IOM, let's see, I don't even know. Well, hold on a second, I might have just made that up. I know it's in my PowerPoint, but maybe it's not here. Okay, let's just look real quick at the Quality and Safety Education for Nurses Institute. This is what I feel like we need to know the most. It's QSEN is the shortened term of it, Quality and Safety Education for Nurses. And I want you to look at this box 48.3 where it tells you some of the competencies that the nurse should be learning in school and should have mastered by the time they finish school. I do have a link on this PowerPoint that I'm about to go over with you to all these websites so that you can see what that looks like. So that's it for the book, but it's not it for my lecture. I am going to open this up. All right. So, well, it's been a while, so I'm not real familiar. Oh, I am sharing my screen. Slideshow from beginning. Oh, okay. I guess you're still seeing that. All right. So quality improvement, the regulatory agencies. I think I am probably on the wrong screens for these, but we're going to go with what we have. So healthcare quality, in any setting where there is interaction with a patient, you have to prove that you are providing quality care. Regulations and standards have to be met for quality care and sometimes for reimbursement. And that's going to be at your hospitals and your nursing homes. Nurses are personally responsible to meet those standards. You can make or break your whole facility because it's your responsibility as a nurse to make sure you are providing the highest quality care there is. So CMS, this is your Centers for Medicare and Medicaid. They regulate organizations, not nurses. The Texas State Board of Nursing and the Nurse Practice Act is what regulates us. So they oversee reimbursement. They measure nursing quality through the data, which then goes to the annual payment, like I was just talking about, pay for performance. Talk about 8 preventable hospital-acquired conditions. You know, one of those is CLABSI, you know, the pneumonia. One of them is the CAUTI, MRSA. Some of these hospital-acquired conditions are things that there should not be ever. And like I said, CMS, they can come in announced, unannounced, irregardless. They are the overseer of all of our healthcare providing facilities. So the Joint Commission, again, if we participate in Joint Commission, CMS then says, okay, y'all have met those criteria, so you're good. That does not mean CMS will not come in, though, to check for themselves. But let's see. So they're the leader in developing high standards for quality and safety. I do want to say the Joint Commission, you can get different certifications through there. I know at Woodland Heights, I got us certified by the Joint Commission for total hip replacement, total knee replacement, as well as inpatient OB care. So I'm very proud of that, but it was a lot of work making sure that we interpreted their standards correctly and then met those standards and could verbalize how we're meeting those standards. All right, so CUSIN, this is what I was telling you about. This is what, as nurses, you need to know. You know, it's preparing nurses with the knowledge, skills, and attitudes necessary to continuously improve the quality and safety of healthcare. And that's why I'm telling you this now. This is going to be interspersed with everything that you're going to be learning. You know, how do we provide quality care? How is it safe? You know, what is your skill level? What are your attitudes? Okay, formerly the IOM. So this is where I was going with last time. I knew I saw this somewhere. So the National Academies of Science, Engineering, and Medicine, which was formerly known as the Institute of Medicine. They work outside of the government because state, CMS, as you can imagine, Medicare, Medicaid is part of the government. So this is independent nonprofit that works outside of the government to provide advice. They provide evidence to make informed health decisions. So when you talk about your evidence-based care and where that comes from, here you go. Okay, so your National Quality Forum. So one of the things, well, I thought this had, well, this has got, the National Quality Forum definitely has a lot of good resources here, but that's really not what I was looking for. So there is something else I'm looking for that I want to share with you as we're talking about this. And again, you can see me where I'm going to get to my resources. The Joint Commission National Patient Safety Goals. Let's see. So one thing I want you to see is they have different goals for different sections. Like this is the hospital goals, and we're going to download this here in just a second and look at it. But they also have it for nursing homes, ambulatory health, laboratory, home health, critical access. So these goals are going to be different based on the setting that you work in. Okay, some of these may be a surprise, but I hope none of them are a surprise to you. Identify patients correctly. 2 patient identifiers, the patient's name and date of birth. Anytime you're in SIM, anytime you are with a patient, you always, I don't care if it's 5 times a day that you have to ask this patient their name and date of birth, you always identify this patient by 2 different measures. Improve staff communication. So this is going to be the test results. This is why they now have the critical test results, and a lot of hospitals will have a time limit. Okay, from the time you receive this critical result, you only have 30 minutes to notify the provider for things to happen. Use medicine safely. Record and pass along correct information about patient medicine. Find out what medicine the patient is taking. This is huge. Whenever you're the admission nurse, you have to find out everything that they are taking at home. And then you're going to compare that to what is ordered at the facility and make sure nothing jumps out at you. Make sure they're getting the medicines that they're supposed to be getting. It's a big deal. Use alarms safely. And we're going to go a little bit into alarm fatigue later on. But this is to make improvements to ensure that alarms are heard and responded to on time. You know, and this is due to the fact that so many times you have these monitors, whether it's a telemetry monitor or cardio apnea monitor, set so specifically that they are going to alarm at every little thing. When that happens, the nurse that's caring for that patient may develop alarm fatigue and just silence, instead of every time going and checking to see what's going on with that patient. So this is the safe use of alarms that they're talking about. And prevent infection. Hand washing is the #1 most effective way to prevent the spread of infection. Identify patient's safety risk. The risk for suicide. We're going to have to, especially those of you that work in the ER will be more familiar with this. Improve healthcare equity. Says, for example, healthcare disparities in the patient population are identified and a written plan describes ways to improve equity. How can you make sure this homeless patient living on the street with $0 has the same access to healthcare as this hospital CEO? I mean, that's probably a big stretch, but that's what it's talking about with the equity. And then preventing mistakes in surgery. So let's talk about that. Timeout. You'll hear timeouts if you work in surgery or if you go look at surgery. They're going to be doing timeouts to make sure they have the correct patient, they're doing the correct surgery on the correct site. The doctor will also mark the site with the patient's approval beforehand. And then they do that pause, that timeout, right before surgery begins to make sure everybody is on the same page and has the same information. So that's what that is talking about. I do have a couple of videos here. QI in healthcare. Quality, again, is huge. You're never going to get away from it. You actually have nurses that are hired to continuously be looking at the electronic health records of all the patients to make sure that everything has been documented that's supposed to be. It is just that big of a deal. So anyway, I do want you to go in, look at this, understand it. If there is anything you do not understand, as always, let me know. Shoot me a discussion, a telephone call or an email so we can talk it out and I can make sure you understand. And that is it for quality improvement.